Thank you so much. It's really an honor to be back at Northwestern and to be invited to speak here today, so thank you so much. I'll be speaking about Fertoprotective Therapeutics and trying to cover kind of the broad range of work that's been done in this field. So to jump right in, I have no commercial relationships to disclose. My work described here has been funded by the ASRM and the Foundation for Women's Wellness. And the goals today will be to review some of the mechanisms of iatrogenic ovarian injury, to discuss some of the limitations of current approaches to fertility preservation, and to examine some of the experimental approaches on the horizon for pharmacologic fertility preservation. So this group is well aware of the decline in mortality among reproductive-age women exposed dealing with cancer and the concurrent increase in survivorship and the importance of focusing on fertility and hormonal function in this population. And what we're seeing in terms, along with these trends, is a trend in delayed childbearing in the context, and what this means in the context of cancer diagnoses. So we understand that in the United States, women are delaying childbearing, as are women worldwide, and the mean age of first birth is 26.4 years. And so what we're seeing is that we're gonna have an increasing number of women who are childless at the time of their cancer diagnosis. So the focus on fertility preservation is even more important. We know that the ovaries have a fixed complement of primordial follicles at birth, constituting the ovarian reserve, and there's a progressive nonlinear decline in reproductive function, culminating in menopause, and unfortunately this is accelerated in women who are exposed to radiation and chemotherapy. And so when we're looking at the options currently available for female fertility preservation, we know the established options are oocyte cryopreservation, embryo cryopreservation, and the investigational and experimental options, hopefully soon not to be experimental, but ovarian tissue cryopreservation, and then pharmacologic fertoprotection. And so when we think about the limitations of egg and embryo freezing, really this is a very limited option. So let's think about a hypothetical 35-year-old patient who comes in to freeze eggs. She may freeze 10 mature eggs. When she comes back to warm these eggs, maybe 80% will survive the thaw, 80% may fertilize, and maybe 30% will go on to create a blastocyst, and we've seen this in our own data previously at NYU that we do see impaired blastocyst formation in embryos derived from cryopreserved eggs. And so this may result in 2 blastocysts. If that same patient freezes embryos, maybe she has 10 mature eggs, 8 fertilize, and she has 50% that go on to produce blastocysts, so maybe 4 blastocysts. And then we have to think about the age of the patient and the risk of aneuploidy. And so the reality is patients have a very limited number of embryos that can go on to produce a pregnancy. And then of course, we're thinking about hormonal function. And so when we think about the ovary, we think about cardiovascular function, we think about sexual health, we think about bone health, mental health. And so we have 2 really important issues here that are, of course, fertility and hormonal function, but we really need to focus on the hormonal piece of things, and this is where the emphasis needs to be on pharmacologic fertoprotection. So when we think about mechanisms of iatrogenic ovarian injury, there's a really broad spectrum of mechanism at play. So there's direct loss of primordial follicles, accelerated primordial follicle activation, atresia, inflammation and stromal damage, and damage to vasculature. And I'm going to go back to this figure a few times to highlight some of the work being done in these different areas. So let's focus now on pharmacologic fertoprotection. When we think about pharmacologic fertoprotection, we think about GnRH agonists, primarily Lupron, because we know that this is really the only available option. We have to remember this is still considered experimental after 30 years of data. And so some of the presumed mechanisms of action here are suppression of FSH, rendering follicles less susceptible to damage from chemotherapy agents, potentially decrease in utero perfusion, a decrease in anti-apoptotic molecules, or increase, I apologize. And so when we think about what these mechanisms have been and what some of the work has been done to evaluate these mechanisms, we know there has been a really vast array of data kind of looking at this. And so let's look at some of the preclinical data in murine models. This is just a small summary of some of the work done in mice, and we see that there have been very mixed results. So we know there have been some results showing protection when looking at GnRH agonists used alongside with cyclophosphamide, a number of studies looking at no protection, so in a number of studies looking at cyclophosphamide alongside GnRH agonists in mice, no difference in proliferation and apoptosis in the ovaries, no protection of quiescent growing follicles, FSH deficiency does not protect ovarian reserve. So for the number of positive studies, we've seen a negative study. Similar in rat models, an equal number of studies showing protection and no protection. And then in some of the preclinical data looking at female primates and human models, most recently in 2015, there was an in vitro study on human granulosa cells and ovarian tissue fragments looking at Cytoxan, paclitaxel, 5-FU, and TAC regimens showing no protection of ovarian reserve, no preservation of AMH, estradiol, and progesterone levels, no upregulation of anti-apoptotic genes, and no preservation of the vascular density. So we have reason to be concerned because we still don't fully understand the mechanism. And our clinical data shows that we are not certain, of course, of the clinical efficacy. And so there have been 14 randomized studies in breast cancer showing potential prolongation of ovarian function, possible decrease in POI, but really no clear benefit in fertility preservation. 2 RCTs in lymphoma showing no benefit, 12 meta-analyses showing potential benefit in preventing POI. And what we know is there's a clear benefit in menstrual suppression. So women with thrombocytopenia at risk of bleeding, certainly these are very beneficial. And we counsel patients that the data are mixed and there may be a benefit in preventing POI, which of course is critically important, but we understand we cannot rely on these for fertility preservation. And ASCO put out a statement encouraging providers to inform patients that there's insufficient evidence regarding the efficacy of ovarian suppression with GnRH agonists as a fertility preservation method, and these agents should not be relied upon for fertility. And when we think about the physiology of the ovary and folliculogenesis, it makes sense why we're seeing these mixed results. So we understand that growing follicles are FSH sensitive and primordial follicles are not. And so we may only be protecting this growing pool of follicles, which we understand, of course, that the bulk of the ovarian reserve is in the primordial follicle, and that is the follicle that we need to protect. And so in thinking about all of these mechanisms of ovarian damage, I'm going to be focusing on the follicular burnout theory right now. So this concept that growing follicles are damaged, and this then results in this upregulation, activation of the primordial follicle pool, which then puts that pool of follicles at risk. And so we have to think about a number of these promoting and inhibiting factors that are at play when we look at folliculogenesis. And so one of these promoting factors that promotes growth from the primordial follicle to primary stage is mTOR. mTOR is a serine threonine kinase. It's a major metabolic regulator. It's involved in numerous signaling pathways, regulating mRNA translation, cell growth, survival, and proliferation. It's upregulated by a number of nutrients, growth factors, some chemotherapy agents, and importantly, it's upregulated in 80% of human cancers. And we know that this pathway is critical to the activation from the primordial follicle stage to primary follicles. And in fact, in knockout models, when PTEN and TSC1 and 2 are knocked out in mice, we see this massive upregulation of PI3K, AKT, and this mTOR pathway because these are negative regulators of the pathway. So knockout of this negative regulation leads to upregulation of mTOR and a POI phenotype in a murine model. So this pathway has been investigated because of a number of potential clinical implications. So when we're looking at activation of primordial follicles, we understand, of course, that this has been interrogated in primary ovarian insufficiency. So can this pathway be activated to recruit some of these dormant primordial follicles? But then the alternative is, and this is my area of interest, is can we manipulate this pathway to preserve fertility? And then also in a broader sense, in the context of ovarian aging. So I'm not going to be talking about that today, but that's also a significant interest of mine, is looking at this pathway to preserve fertility and potentially prolong reproductive longevity. And so my group previously looked at could we potentially use mTOR inhibitors, clinically available drugs, to preserve ovarian reserve and fertility in mice treated with cyclophosphamide. The idea being we administer these drugs concurrently with chemotherapy to suppress this activation. And it's important to think about the broader context here because mTOR inhibitors are widely used for a number of benign and malignant conditions. So I'll be speaking about 2 mTOR inhibitors. mTORC1 inhibitors are everolimus or RAD-001. This is one of a number of medications in this class, rapamycin being the original, and then there have been a number of iterations of this drug with different bioavailability and pharmacokinetic profiles. But everolimus in particular is FDA approved under the trade name Afinitor, made by Novartis, in the treatment of estrogen receptor positive, HER2 negative breast cancer, advanced renal cell carcinoma, a number of astrocytomas and tuberous sclerosis, and there's a growing list of indications for this particular drug. Dual mTORC1 and 2 inhibitors, which I'll be referring to as INK-128, have been used in a number of preclinical trials, but are not yet clinically available. And so we used C57 Black 6 mice and dosed them at 8 weeks of age. They were dosed with either RAD-001, so our mTORC1 inhibitor, INK-128, our dual mTORC1 and 2 inhibitor, cyclophosphamide, RAD with cyclophosphamide, or INK with cyclophosphamide. And the mice treated with mTORC inhibitors were dosed orally, so via oral lavage, to simulate the dosing that would be used in humans because the dosing of these medications is oral. So our first aim was to look at ovarian reserve. Mice were treated for 3 weeks daily with mTORC inhibitors, and then weekly with cyclophosphamide intraperitoneally. And then on week 4, so 1 week after the last dose of cyclophosphamide, mice were sacrificed. And aim 2 was to look at fertility, which we will get to next. We first found that in whole ovary lysates of the co-treated mice, we saw downregulation of mTOR activity. And so looking at the mice that were co-treated with cyclophosphamide and RAD and cyclophosphamide with INK, we saw significant downregulation of phosphorylated AKT, phosphorylated S6 kinase, and phosphorylated 4-EBP1, so really molecular substantiation that these drugs were working as we intended for them to work. They were downregulating the pathway. And then within primordial follicles using immunohistochemistry, we saw that there was a decrease in phosphorylation of 4-EBP1 and S6 kinase within the follicle. So, particularly within our follicle of interest, rather than just looking at the whole ovary lysate. And when we did our follicle counts, we saw that there was a 2-fold increase in primordial follicles per surface area when the cyclophosphamide-treated mice were co-treated with mTOR inhibitors. So significantly fewer primordial follicles in the cyclophosphamide-treated mice, and this was improved with the co-treatment with mTOR inhibitors. And then this concept of follicular burnout, this means, of course, that there is an upregulation from the primordial follicle stage to a growing follicle. And so when we looked at follicle counts and evaluated the ratio of total growing to primordial follicles, we saw that this ratio was significantly increased in the cyclophosphamide-treated mice, consistent with an upregulation from primordial to growing follicles. And this was attenuated when we co-treated mice with RAD and INK. And then looking next at our fertility aim, we wanted to then assess, are we then seeing an improvement in fertility in these cyclophosphamide-treated mice? So the experiment was repeated now for a longer duration. So mice were treated for 4 weeks with their mTOR inhibitor and with their cyclophosphamide to induce more stringent criteria for subfertility. They were then allowed 8 weeks, and then 8 weeks following treatment were harem bred with a proven male breeder, and we then assessed for pups. And what we found was that the cyclophosphamide-treated mice had significantly fewer pups per litter, and 2 of the 5 were infertile, whereas the co-treatment with the mTORC inhibitors preserved normal litter sizes, and there was no difference in pup weight or pup anomalies. And so this work is really a drop in the bucket of the work being done. And so I'm going to focus on some of the broader, field of pharmacologic fertoprotection, and this work really falls into this area of follicular burnout. There are a number of other studies I'm going to focus in on in this area as well, and then talk a little bit about some of the other areas, including apoptosis and addressing maybe ways to promote anti-apoptosis. So looking at this landscape of follicular burnout, in 2013, Dror Myro's group in Israel published on their work looking at follicle activation and the use of the immune modulator AS101 to prevent follicular burnout. So they first described that mice treated with cyclophosphamide had an increase in phosphorylated AKT, an increase in phosphorylated mTOR, S6, and FOXO3A, all consistent with an upregulation of this pathway, which would be consistent with the burnout we described. And these, on your right, these are the immunohistochemistry stains looking at the substantiation of what they described with their Western blots. And what they found when they performed their follicle counts is this similar concept where they had significantly fewer primordial follicles with increasing doses of cyclophosphamide, and then preservation of follicle counts with co-administration of AS101. And AS101 is an immunomodulator that is thought to modulate, again, this PI3K-AKT pathway. And ultimately, their fertility data showed that their mean litter size per pregnant mouse was significantly smaller with cyclophosphamide and attenuated, improved with their co-administration of AS101, and ultimately cumulative pups were significantly greater when they co-administered with AS101. Similarly, in 2016, a group reported on the use of melatonin, first describing that with cisplatin, they saw a significant increase in phosphorylation of P10, phosphorylation of AKT, and FOXO3A, also consistent with the possibility that cisplatin upregulates this pathway, and so leads to diminished reserve via upregulation of the PI3K-AKT pathway. And they then co-administered with melatonin and found that they saw downregulation of all of these downstream markers of the mTOR pathway. And ultimately, this led to preservation of their primordial follicle counts. And so AMH was mentioned earlier, and of course, there's been a lot of discussion about AMH, and we know AMH to be a very important regulator of follicle growth. And there was a very interesting paper out of PNAS in 2017 out of David Pepin's group from MGH, and they looked at AMH as a means to prevent follicle activation as well. So what they did was they administered AMH via gene vector therapy alongside chemotherapy agents, and found first that, of course, there was an increase in when they administered MIS or AMH via gene vector therapy, they saw an increase in primordial follicle counts in the mice treated with gene vector therapy, and then ultimately they treated mice with a recombinant MIS pump and found that this pump essentially produced a constant infusion of MIS and prevented follicle growth. And interestingly, they found that this persisted throughout the reproductive lifespan as long as that pump was consistently activated. But when they stopped infusion of the MIS, mice resumed folliculogenesis. And so moving on to some of the other means of pharmacologic photoprotection. So there's certainly a lot of data surrounding direct loss of primordial follicles and apoptosis. And this is work that was published in Nature Medicine in 2009, looking at inhibition of the c-ABL TAP63 pathway, looking at cisplatin acting primarily via apoptosis to result in DNA damage. And this group used imatinib to prevent this activation of the P63 pathway. And this is a figure that Dr. Woodruff published as a commentary to that Nature Medicine paper. And as some follow-up work, Dr. Woodruff's group looked at rescue of platinum-damaged oocytes from programmed cell death through inactivation of the P53 family signaling network. And here they show that cisplatin-treated ovaries had damaged follicles. You see this pink cytoplasm and condensed nuclei. And they co-treated mice with imatinib and found healthy-appearing primordial follicles, and in fact, significantly more primordial follicles in the co-treated mice. And more recently, Soo-Yeon Kim's group, she was previously in Dr. Woodruff's lab, published in the Journal of Endocrinology on inhibitors of apoptosis protecting the ovarian reserve from cyclophosphamide, looking at the effect of cyclophosphamide metabolites in 3 different murine strains, identifying that primarily the method of injury in that study was apoptosis, but identifying that phosphorylated AKT was upregulated in the primordial follicle, primordial oocytes 3 days after Cy injection. So some interplay here between AKT and apoptosis. But I think the message you're probably hearing, what I'm trying to convey, is we've seen a lot of overlap between these mechanisms of injury and a lot of overlap between the mechanisms within different chemotherapy agents. And so focusing lastly on sphingolipids. So sphingolipids are a class of lipids that are really critical to signal transduction, and there's been a lot of work being done in this area as well. So sphingosine 1-phosphate has been shown to prevent chemotherapy-induced human primordial follicle death. So this is Octay's group. They cultured human ovarian tissue and mouse ovarian tissue with sphingosine 1-phosphate and found that it mediated Cy-induced apoptosis, so this is an apoptosis index, and significantly less apoptosis in the groups that were co-treated. And Mary Zielinski's group did some really interesting work in this area looking at radiation-induced apoptosis, showing that when they administered sphingosine 1-phosphate intrabursally, as well as a sphingosine 1-phosphate mimetic, FTY720, in rhesus monkeys, they saw attenuation of radiation-induced oocyte loss. And in fact, they saw that these oocytes were protected from DNA damage and that their F1 and F2 offspring were healthy. So really interesting and provocative work. And the thought is that we know oxidative stress induces mitochondrial dysfunction, leads to activation of caspase-3, and sphingosine 1-phosphate may inhibit oxidative stress-induced granulosa cell apoptosis, potentially suppressing caspase-3 release via the PI3K AKT signaling pathway. So again, a lot of interplay between these pathways. And another group out of Argentina looked at ceramide 1-phosphate with having protective properties against cyclophosphamide-induced ovarian damage in a mouse model of POI. They found that C1P decreased Cy-induced apoptosis. So again, this is an apoptotic index looking at the administration of Cy alone here, alongside Cy with C1P, so significantly less apoptosis in these follicles. And then they showed also a reduced Cy-induced stromal vascular damage. So this is showing some vascular damage, and they demonstrated decreased vascular damage in the co-treated groups. And then just switching gears because it was interesting, but unfortunately did not launch. There was some interest in tamoxifen as a fertility preservation agent. So some interesting work back in 2010. There was a follow-up RCT done in Sweden that did not show any benefit. But I think this is just to show that there has been a really broad range of work done in this area. And unfortunately, we are not much further than where we started in terms of clinically available agents, but I think we are moving in the right direction. And so this is just clearly a busy slide looking at a list of some of the work that's been done in this area. This is just the last 10 years. So I think that's a fair amount of progress for 10 years, and certainly hopeful in terms of the direction that we're going in terms of pharmacologic fertoprotection. And as we further identify mechanism, we'll be better able to identify targets. So some of the limitations of the data that is currently available, this is all preclinical. So we understand there are limitations to using animal models, and we know that a lot of these animal models are really varied. So different mouse strains, different rat strains, a lot of variations in terms of timing of administration. And then the regimens are varied in terms of these studies. And we understand that patients are not receiving one agent, they're receiving polypharmacy. And so when we're looking at these studies that are focusing just on cyclophosphamide or just on cisplatin or any individual agent, we understand this is not the reality of what patients are facing. So when we're thinking forward to what qualities are going to be important in a fertoprotective agent, there are a number of things that we have to think about. Cost being one of them. So if I'm looking at my own experience with everolimus is extremely expensive. It will likely be going off patent soon, and so it may become more affordable. But the reality is that this will be a very expensive fertoprotective agent. Route of administration, so this would have to be something that would be easy for patients to take, oral ideally. Tolerability, so what are the side effects? Everolimus, one of the major limitations would be there are a number of side effects, and for the oncologists in the room, I'm sure you could attest to that. So these are used in a number of oncology treatment regimens, and there are stomatitis side effects and nausea and GI side effects and rarely some pulmonary side effects. And so we would have to dose these appropriately for fertility preservation, understanding though that, that side effects could be a major limitation. Availability of these drugs, and then efficacy, of course. And so we should also then be thinking about how can we repurpose the drugs that are already available. In the case of mTOR inhibitors, because they're FDA approved, it might be a little bit easier to move something like that forward, but there can be certainly so many other examples of similar drugs that are already approved. So I'm going to end with a comment by Dr. Woodruff, and this was a commentary that she wrote in response to the AMH paper in PNAS in 2017. So this is a win-win for women's reproductive health, a non-steroidal contraceptive, and fertoprotective neoadjuvant. And then a word of cautious optimism from Dr. Woodruff. So she notes, in the case of a fertoprotective therapy, we may protect the oocyte from death, but damage to the germline may persist, increasing the likelihood of birth defects. And I think that's a critically important point, that we have to remember what is the health of the oocyte that we're protecting. So I'd like to thank the Northwestern University Fertility and Reproductive Medicine group. It's been a fantastic group to work with in this, these last months as I've started here. The Northwestern Center for Reproductive Science, Dr. Woodruff, and Dr. Duncan, who I'm so fortunate to collaborate with, and she was my blinded follicle counter on my paper, and she's just a phenomenal scientist and collaborator. The New York University Langone Fertility Center, so my co-authors, Dr. Griffo and Dr. Keefe, and Bob Schneider from the Schneider Lab at NYU, where I did my work. And then Joyce Reinecke at the AFP, who's going to be speaking next. And just a plug for her, she's doing such incredible work to move the field forward in terms of access to care for our patients. And then just a specific mention to Kristen Smith, who is, this program wouldn't run without her. So thank you. Thank you so much.